Welcome. Come with me. The doctors will see you now.
Welcome back to Fast Talks with Family Docs. I'm Dr. Phil Palmer.
And I'm Dr. Vera Badala. We're back again with Dr. Mary Clarke. We've been talking all things OSMA and her experience during the COVID-19 pandemic and how we as physicians and providers should be involved in spreading a positive message and avoiding misinformation to our patients, keeping our community healthy. Dr. Clarke, thank you for joining us again today.
Absolutely.
Yes. Hey, we've talked about your involvement as OSMA president and your experience during the COVID-19 pandemic, but reading about you and getting to learn a little bit more about you, you've had this career where there's an intersection between medicine and education and public policy, and it sounds pretty complex to kind of walk all those lines, right? But you have shown that those areas can all collaborate together to improve community health, right? And there was this program called the Healthier Oklahoma Coalition that we had read about, and we would love to learn more about it if you don't mind sharing.
I would be happy to share. Early in the pandemic, within the first 6 months, it was obvious that there was a lack of real information across many different associations. The healthcare community alone, we have, the infectious disease community and the state medical association and the family medicines and the pediatricians and oh, by the way, the educators. It became obvious that no one really had a one place to go to for information, right? Because I'm trying to be political, but because the state really was not giving information, I don't feel like they were trying to give misinformation. Maybe that's not enough information.
Sure. Yeah.
It was a vacuum. And we decided that we would build a coalition of any stakeholders that wanted to be part of a weekly video chat, basically. That's what our coalition started out as. And Dr. Jean Househair, who was also a past president of the association, she was a few years before me. I have to count back, 1, 2, 3, I think 3 years before me. So recent. And she became the driver of this coalition. And we invited everyone. So every Monday night at 6 o'clock or 7 o'clock, anyone who wanted to be involved could do this. And she would set up a couple of people to answer some questions, some pertinent questions for that week. Especially during the session, especially when we were in session, what bills were coming through, how are we going to handle this, what does that mean for healthcare? The Oklahoma Hospital Association was involved. There were probably 17 or 18 different stakeholders. Wow. That some representative was on the call. And we did that every week, every Monday night for, Jean can tell you, at least the entire year that I was president.
Wow.
And that started before that. Mm-hmm. So it started in the presidency before us with Dr. George Monks. That was all, and it just became this snowball effect. And you realize how many people really were just dying for information. And so we had these representatives from these multiple associations around the state getting information from us as we had, picked up data for the week, death rates for the week, spread rates for the week, school systems, who's open, who's closed.
Wow.
And that got discussed that for that hour, and then they disseminated that to their people for more information. And that was, I have to give it to the Medical Association and Dr. Househair, because they did the 99% of the heavy lifting for that. Mm-hmm. And they would do all the research for the week, over the weekend, ask questions, set people up to give the discussion for the week, and then anyone could ask questions. On top of the coalition, we did a Tuesday noon media interview every Tuesday afternoon, and that started also in the prior presidency. And every Tuesday afternoon, same thing. that was all media was invited. Any media who wanted to be invited, we had a Zoom call. Same thing. 2 or 3 people would give a small blurb, different elements of how things are going in different parts of the communities, and then they would throw questions back at us.
Okay.
In that, so we had our association coalition on that Monday nights, and then Tuesday we'd have our media interviews every Tuesday at lunch.
Yeah.
And it was really amazing to see how many people needed that information.
Yeah.
It was, I would have never thought that we would be the ones giving weekly updates and information and death rates and things like that, because there was just no one else to do it.
Yeah. You saw a need and then you stepped up to fill that void. It's like a recurring theme from our guests in our podcast. And that sounds wonderful. Is anything like that still going on through the OSMA right now?
That has slowly but surely slowed down. We went to every other week for the last, I don't know, I want to say a couple of years. And I think they went to once a month, and now I think it's as needed.
Okay.
So I don't think they're doing it on a regular basis.
Sure.
But I will tell you, if we have another event,
Yeah.
I will promise you that will be right back on probably Monday nights.
Okay.
Because they did we know how to do it now.
Yeah.
And it's not hard to pivot to do podcasts like this and media's interviews and an hour here or there. People can do it anywhere. You can do it in your car.
Yeah.
And we had that a lot. We had tons of people driving in between places, listening to data and information.
Well, and it gets back to what you shared on our last episode, is that one of the cornerstones when you're dealing with a difficult situation in healthcare is communication. The healthcare providers need to communicate with each other, but then we need to communicate clearly an understandable message to the general public and to legislators and to the media.
Yep. Absolutely.
So it's easy as someone that has an interest and a passion in leadership and in advocacy to embrace those issues of public health, public wellness, understanding of social determinants of health, the need for ongoing patient advocacy. But only a small subset of the physician population is ever going to be in that position of leadership. What do you think is important for the docs in the clinic who are just busy seeing patients and sometimes trying to keep their head above water and keep their staff employed and keep their doors open? What should they grasp? And what do you think it's important for docs to understand about the role of an individual physician being an advocate?
That's another good question. You're exactly right. Not all physicians, obviously, in the state of Oklahoma belong to the Oklahoma State Medical Association. We are a state that to have a license, you do not have to belong to your association. Some not. I don't know of any state for medicine that does that, but like the Bar Association, you have to have a bar to be on the bar in Oklahoma. You have to belong to Oklahoma Bar Association.
Oh, okay.
So that's not what the medical association is. Right. We haven't done that in a long time. I think there was a point in time, but it's been a very long time. So how do you keep physicians engaged in being that advocate and understand that you don't have to be in leadership to be an advocate?
Yes.
You don't have to be in the leadership track that we engaged in going, to be the president of the association, which none of us ever really expect, to be honest with you.
No, that's true.
I mean, I would have never said 20 years ago that I would be a president of a state medical association. I would have never, in my wildest dreams, ever thought that was going to be in my future. But you don't have to be in leadership to be an advocate. That's not, they're not, they can separate that. You can be an advocate because, remember, you are an advocate for your patients every day.
Yes.
Every time you walk in the door to see a patient, you are being their advocate at that point in time.
Yes.
What we need to understand is expand that a little bit outside your door. Take your patients' experiences, take the things that they tell you and how they're going through their health system and what's good and bad, and pass that along. You don't have to go to the Capitol and lobby the Capitol on Medicine Day every year with your white coat, because that's uncomfortable for a lot of people. It's hard to go and talk to your legislators. Even though we are some of the smartest people in the world, it is hard to step into Congress and tell them what you want them to hear until you do it.
Yes.
So expecting everyone to do that is not really realistic, but help them understand they're a leader regardless of where they are. You don't have to be a president. You're an advocate for your patient every day.
Right.
And if you make one email or one phone call to any of your representatives or senators, either locally or your mayor or your federal Congress, that's all we need everyone to do.
Yes.
The other question, I'm gonna take that one step further if this is okay.
Absolutely.
How do we get the rest of the physicians who are not part of our association involved in the association?
Yeah.
That's a different question.
That's a different question.
Yeah.
That becomes more complicated because we as human beings, if we don't like something, we take our toys and leave.
Right.
And there, as a state medical association, because we encompass all specialties, sometimes those don't always mesh together.
Right.
If we're talking about Medicare payment models, pushing toward primary care, family physician, internal medicine, increasing payment models for them, you're going to be taking that away from the specialty care because it has to be by law, as the budget neutrality has to be a zero-sum gain. So how do you bring all of those people together and not get mad at each other and think it's just them, just me? Whereas you said the AMA at the time was very highly specialty driven in our last episode. It is not so much today.
Correct. It is not.
It is very, very different because the primary care physicians have said, we want to be involved.
Yes.
Yeah.
And so getting more physicians as part of the association is really that is a hard one because if you don't like what I'm telling you, then you're going to decrease your reimbursements next year because the family docs are going to have a 3% increase. That's a hard pill for people to sell, to swallow. Understandably so. So how do we make it to where, yes, that's going to suck, but in the long run, I'm going to have healthier patients for you, so it's not going to be so bad when you're treating them.
Yeah.
How do we really get that? And the only way to really do that is it's kind of a catch-22. You have to be involved and understand that the people that are in the association do that.
Right.
Yeah.
And we try and do that as well as we can. And until you're really there and you go to meetings and you meet people and you say hi and you understand the workings of how we set resolutions and why, then you understand, oh, okay, this is a betterment for everyone. Tomorrow it may not be in my favor, but it's in the favor of all patients because that's going to make a better healthcare system.
Yeah.
But it's, again, catch-22. You have to be there to feel like it's important, and the only way you're going to be important is if you be there. So it is just, trying to get your local new docs involved and saying, hey, bring someone to the next meeting and get them involved. And just, we need to be an advocate for ourselves too, for each other.
Yeah. It's just a matter of being involved. And I've mentioned this on other podcasts, but jumping back to something you said a minute ago is just making a phone call or writing a letter, writing an email. There are men and women who are taking the time to serve in the legislature, state level, national level, that they want the best for Oklahoma, but they can't possibly understand every nuance of the law and industry and private grocers and medicine. And so they're taking information from the people who put it in front of them or speak it into their ear, who send them something, and they're doing the best they can. And so they're very responsive to a physician reaching out and saying, this isn't good for the people of your state or your district or your town or whatever the case may be. And I've found, not that every time I call, votes go the way I think they ought to go, but I've found people very responsive to hearing opinions of people that they represent. And I think that's one message that the docs, whether it's looking at engagement with the Oklahoma Academy of Family Physicians or the Oklahoma State Medical Association, whatever the case may be, is be involved and take that effort to communicate with someone and share your thoughts, because it will make a difference. And if we all do that, it'll make a huge difference.
I think that strength in numbers is key, sir, because as an individual level, me picking up the phone and calling my senator, I'm like, well, I'm just this family doc in this primary care clinic. Why would the senator talk to me? But it's, once you don't know how responsive these people are until you talk to them first and gain that experience. Right. And I think that's where the strength in numbers would come in, because then everyone, you do it, then you tell your experience to your friend who's a physician, and they can try as well. And the healthcare field is ever changing, and a lot happens within our system. And to me, as I'm relatively new in my career. It's my 5th year after residency, and a lot of things kind of happening in the healthcare system now, whether it be AI, like where's that going to take his scope of practice? We've already talked about that multiple times in multiple episodes. But Dr. Clarke, I wanted to ask you, what do you think is like the most challenging thing for physicians in the healthcare system now, and where do you see that going in the future? And how can we, as physicians in general, not just family medicine, but all specialties, be involved and work together to kind of improve that situation?
That is the hardest question you're probably going to throw at me.
Yeah, we're sorry.
I think the situation that we're in right now, we've never been in.
Yeah.
And, next year, 10 years from now, it'll be something different. That'll be a challenge. We look at the basic challenge of funding. How do we fund good quality healthcare in the United States? And this obviously becomes a very huge medical economic discussion on top of that, so that we can't discuss here, obviously. But one small change in any part of our healthcare system has a ripple effect across everything. And the challenge right now is going to be with continuing Medicare cuts. So if anyone does not understand this, I'm going to diverge just a moment.
Yeah, of course.
The big thing about Medicare cuts, and we've talked about this for years, that we get small little 2%, 1%, 3%, 4% Medicare cuts every year.
Mm-hmm.
That's on top of inflation.
Mm-hmm.
Right.
And that compounds itself, right?
Yep.
So we might get a 2% cut, and 2% cut in a salary for reimbursement. Okay, that may not be terrible. That might not be, but we had 6% inflation last year,
Right.
plus a 2.3% cut in reimbursement. So we really had a,
Like a 12%.
12%, right? And that's important, because if your physicians can't bring salary in and pay their staff, then they close their doors.
Mm-hmm.
What most people don't really, and that's obvious, right?
Yes.
I mean, if I can't get paid and I can't pay my staff and electricity and my rent and water and all this, I don't have, it's like any other small business. Even in large corporations, the business model is still the same.
Yes.
If I don't make enough money, can't pay my staff, we have no business.
Mm-hmm.
But what a lot of people don't really understand about Medicare is that insurances, all private insurances, float their reimbursement rates to Medicare.
Mm-hmm.
So the healthcare system in the United States is not a free floating system.
Mm-hmm.
The government decides what Medicare rate will be, and all healthcare, all insurers peg to Medicare.
Mm-hmm.
And if you get a 2.8% cut in Medicare, then you will get a 2.8% cut of all insurers. And I don't think a lot of people really understand that. And that's where you get a big ripple.
Yeah. Right.
Because most of the time, businesses stay open because we cost shift to the private insurers, right? So a private insurance A may pay 108% of Medicare.
Yes.
That's kind of how contracts are done. And these contracts are done every 2 to 3 years, and they waste a lot of time and they waste a lot of effort, and everybody does it, and all insurance do it, and it's terrible.
Yeah.
And it's a game of chicken every year, and it's just awful. But this decision about the healthcare and Medicare payments is a real problem. And in the last 20 years, I think we've had a 30% overall, accounting for inflation, 30% decrease in reimbursement rates for Medicare for physician in the last 20 years, accounting for inflation on top of that. 30% salary reimbursement cuts. So now we have increases in diagnostics, in how we treat people. And so there's increased costs there. You have to renovate your buildings periodically. Those costs are extremely high right now for many different reasons. So the healthcare system is what people don't understand is so complicated. Medicare stands to be a shining part of this if we could get that. However, we're having a hard time in our federal legislature to get those things done because right now we don't want to increase taxes. We want tax cuts. We want to pay less for services. But you can't do that when you have more and more people going into Medicare because of the baby boom. We're not through we're continuing to increase yet. When I was a medical student 25 years ago, we were already talking about this.
Yeah.
This was not. This is nothing new. This is a slow train wreck coming down the train track, right? And so now we're seeing that, and the patients are going to really have to be the ones that have to. I mean, we need to be involved, of course, but patients are going to be the driving force. And the only way the patients are really going to understand that is if we hear talks like this, listen to their physicians, and by the way, they're going to have less services because when they start having less services, then that's when they get politically active and involved to talk to their legislators. And when they can't find a family doc who's seeing new Medicare patients, that's really, they get upset. And sometimes it's directed at us, understandably, because they're upset, right? My family is moving into town. I have 2 parents and an aunt, and they're all going to move into town, and especially in small towns. There may not be anyone who is taking new Medicare patients because you can't. You can't take more Medicare patients and keep your doors open. So I think that becomes the real challenge in the healthcare system right now. And you have one part of the aisle says, let everything free market 100%, which you really can't do because it's pegged. And then you have the very far other side that says we need to make single payer system for everybody and just move to a single payer system. And I don't think neither one of them is going to be really an option in the United States, but it doesn't mean we can't find something in the middle. And it's going to be different and new and never done before. But you know what? A democracy was not really ever done before we built a constitution, right? And 3, the president and the Supreme Court and our Congress. So we're smart people. We can probably find a way to do that, but you have to have the political will to do that. And in times of turmoil in our politics, because politics and medicine and education overlap, that's going to be really hard to do at the moment. I don't know how we're going to get out of this right now. But I'm also not in the I don't do a lot of federal lobbying. And I know there's a lot of backdoor discussions, and they're talking all the time. And our Congress at the federal level is on our side. But at the same time, you have the same amount of money for Medicare. You have increased patients. You're going to have less services. So some things going to get cut. But you got to do it you have to make sense of it. You can't just say we're going to cut waste and fraud because we saw one physician in Florida who billed the CMS $150 million for home health services that were never given, right? I mean, we hear about those. And those are rare. Those are few and far between. Otherwise, you'd hear them all the time.
Exactly.
The rest of us are just trying to see our patients and take care of them best we can, understanding the limitations of what we can do. There's no perfect answer. A single payer system is not a perfect answer either necessarily, but there's something that's the same. Because remember, Medicare is a single payer system.
And I think, as you said, there's there's a point in time when people say, this is a crisis to me, and then they're going to do something to try and fix it.
Right.
And I think we're within 10 years of a huge portion of the population saying this is a crisis and something has to be fixed. Hopefully we can bring some fixes before we get to that crisis. But yeah, we've been seeing it coming for a long time, and we're about to be where the bridge is out.
And it's so much more expensive
Yeah.
to fix a crash after
Yes.
the event than to just lay new track.
Right.
Yeah.
Exactly.
Right?
Yeah.
Exactly.
And we all know that. We know if we can get people taken care of ahead of time that we can prevent so many of these things down the road. And we'll save 60 or 70% if you think about it, if you do that. But that's going to take a generation or two.
Right.
Because it's taken us a few generations to get here. And that's really hard. That's a hard sell for politicians because they're probably not going to be in Congress 30 years from now when they're working on the third generation. Yeah. And oh, by the way, our obesity rates have finally dropped below 15% in our children with all these efforts. They're not going to see that down the road. Right. So it's a hard sell.
A battle. Yeah.
It is.
It's an uphill sell. Dr. Vidala, great seeing you again.
Yeah, always, sir.
Dr. Clarke, appreciate so much your time and being a part of our podcast and sharing your expertise.
Thank you.
And viewers and listeners, join us again next time for another episode of Fast Talks with Family Docs.
Thank you for joining us today. The doctors would like to see you back for another check-in. Please choose to follow our podcast and you will automatically be notified when it's time for your next appointment.